side, my own colleague, Dr. Amit Kumar. He is a pediatric intensivist and pediatric, looking after our pediatric ICU also. Sir is a vast experience at pediatric cardiac unit also at our hospital. And sir will be have a research, and he is instructor of many CCLS, IAP, ALS, BLS. And today he will enlighten us with the last few years recent advances in pediatric emergency medicine. Welcome, sir.
Thank you, ma'am. I am beginning on the pediatric emergency updates. Only the recent updates. I won't be too elaborate because everybody has a lunch. So I do not want that we should sleep now. So just an overview. I'm basically discussing about the new guidelines which have come up on sepsis, the new definitions, some portion of CPR which has already been taken by Dr. Abhishek. So I won't be repeating the same. Emerging care in ARDS, pediatric mental health issues, preventive medicines, and imaging in ER, along with the use of AI, which is coming rapidly in our settings. Coming to the pediatric sepsis, in 2024, Finnish criteria came, which changed the definition of sepsis for pediatric patients. And it made our life easier because previously we were following the 2005 guidelines which based on SIRS, which was too sensitive, too much of false positive was there. This narrowed down, and this was applicable for even for the developing countries. So we are routinely using Finnish criteria after that, but this is only about diagnosing sepsis or septic shock. What about management? So we all know, just now recently this guideline has come, surviving septic campaign guideline 2026. This month only it has come. So this talks about the updates. I am only discussing the updates, not the entire guideline, because it will be a topic in itself. So what are the changes that I will only say. So these guidelines have updated few terms like sepsis, septic shock, probable sepsis, suspected septic shocks, and septic shock with persistent hypotensions. The notable is that in septic shock, isolated cardiovascular dysfunction with no impaired perfusion is a septic shock in the presence of infection. And this is the flow chart about the management of sepsis. Many things are old in the previous guidelines. I'm not going to repeat it. We will come with only with the updates. So in this guideline, the blood lactate at the time of presentation in trauma has been incorporated as an initial assessment part. Previously it was not there. It was only for management of septic shock. And apart from having a protocol in the hospital, there should be a performance improvement program in the hospital to look for the audits, to look for the care of septic patients, whether it is improving, worsening, or what is the lacuna there. This will improve the care of sepsis in a hospital settings. As we know that beta-lactams has to be given in infusions instead of a bolus, but this guideline says that there is insufficient evidence to say that this beta-lactam antibiotics has to be given in infusion. Although I would like to add that in adult guidelines, the same body has said that it should be given in bolus. So pediatric evidence is lacking. Maybe in next guideline we will see that there is a recommendation for that. And we all know that procrastination is used for de-escalation of antibiotics. This guideline has added that if you are following a good antibacterial CWRC program, no need to follow for procalcitonin as a de-escalation strategy. This guideline again re-emphasize the role of clinical markers in managing sepsis, because we are moving towards the advanced hemodynamics, and so that's why this was re-added in this guideline. In case of shock, when we have a central line, the use of mixed venous oxygen saturation more than 70% has been re-emphasized. It was there in 2001 guidelines, reverse guidelines that came initially, gold artery therapy, and then after that it was lost, so it was again re-emphasized. And as we all know that POCUS is becoming common, So these guidelines have incorporated the use of focus in the care. We all do. We all start ionotrophs from peripheral cannula when the child comes in the ER. But this evidence was lacking. So previous guidelines are saying they were not recommending use of peripheral cannula for ionotropes. But now this guidelines update is there that we can use as a first modality for using ionotropes. Later on you can put a central line. In the fluid refractory shocks along with severe vasodilatory shocks not responding to noradrenaline, vasopressins. Many centers use methylene blue angiotensin too, but the guideline says that there is not sufficient evidence. It doesn't mean not to use, but evidence is lacking in pediatrics. I think it is true also for adult guidelines. This is a bit new. Less is more. So now least is more. The saturation targets have come down further. If you are giving oxygen therapy, the target is only 88 to 92%, not even 92 to above. So restrictive is better. We know that in metabolic acidemia we should not give bicarb, but some studies have found there is some utility of bicarb in certain conditions, but the guideline is silent about that, so as not recommending it. About the use of extracorporeal blood perfusion like oxalis, cytosorb, palmaxin B, which is very evident in corporate practice, but guidelines doesn't recommend it because there is no sufficient evidence that it provides a morbidity or mortality benefit. The guideline has again emphasized the role of fluids. It is becoming again restrictive strategy. So we should not give too much fluid during recitations. We have to monitor the fluid intake, and when patient becomes stable, you have to take out the extra fluids if there is a fluid overload. The only thing is you have to take care that we should not become hypovolemic, again circulatory compromise will happen. So the fluid role is very important in sepsis. From the earlier liberal strategy, now it is becoming more restrictive. And this guidelines has given a new updates on the phenotypes of sepsis. So we all know that in time of we use plasma exchange, but there is insufficient evidence for pediatrics as well as in adults. In a case of immunoparalytic state of sepsis, we use colony-stimulating factor to increase the neutrophil counts, but there is insufficient evidence to recommend it as per the guidelines. And the third category of third phenotype is hyperphenytemia. We use immunosuppressants, steroids, anakinra, all those to control the sepsis, but the guideline doesn't recommend it because evidence is lacking. Maybe in the future it will come. This insufficient evidence doesn't mean not to use, but at present the evidence is not there to recommend. This is one of the U-turns of the guidelines which keep on coming every 4 years. The previous guidelines were saying that against the use of high volume hemofiltration when RRT is used, but this guidelines is now for saying that now we should use high volume hemofiltration when RRT is being planned in septic patients. And regarding early rehabilitation bundle, it should be used in all septic patients because we have to not look at the immediate problem of sepsis, but we have to see for the long-term complications of sepsis, like emotional, psychiatric, neurological complications that we have taken care of. So the bundles will be applied when the child admits as a septic patient. Now sepsis is over. Now coming to the pediatric advanced life support, what are the current updates in 2025? Dr. Abhishek has already told, so I'm not going to repeat that which he has already mentioned. So I'm skipping this, I'm skipping this, I'm skipping this. There was a change in this guideline that in non-soccer rhythm, adrenaline has to be given as early as possible, within 5 minutes ideally. But in case of soccer rhythm, the guideline was not clear previously, but in this last year it has said that adrenaline has to be given after 2 attempts of defibrillation, although it was there in adult guideline, but pediatric was lacking. Now it has been updated in pediatric also. But if there is no provision of defibrillation, you can give early also. The other guidelines are almost same, so I'm not going to repeat it. Only thing that we were expecting the uniformity of chest compression is to ventilation ratio, which was supposed to be changed, but it has not been changed. It has remained the same. So with two senior rescuers, when it is child or infant, it is 15:2. Single rescuer is 30:2, and others it is only 30:2. About the blood pressure targets when the ROSC has been achieved. So this guideline has modified it. It says that it should be 10 percentile of systolic and mean blood pressure. Previously we were either 5% or 50%. And when we are monitoring the blood pressure, arterial lines will be there. This is one of the important updates which was not there previously. In pediatric we were not sure how to prognosticate after ROSC. So this guideline has updated that if pupil reflex is there in the initial 12 hours, it indicates a good prognosis, neurological prognosis I'm talking about. But the guideline says that it should not be taken in isolation, all this will be combined, and absence of this doesn't indicate a bad prognosis. So the contrary view is not correct. Similarly, presence of normal lactate within 12 hours is good prognosis, but absence of normal lactate doesn't indicate a bad prognosis. Reactive EEG changes in 6 to 24 hours indicates a good prognosis. Normal EEG in first 3 days is good prognosis. Sleep bundles in EEG is a good prognosis in the second half of the first day. And after 3 days, MRI when comes normal, it indicates a good prognosis. Coming to about the bad prognosis, in the initial 24 hours, if CT scan showed loss of gray matter, white matter differentiation, then it indicates a bad prognosis. But again, I will highlight that normal CT scan doesn't means bad prognosis, good prognosis. EEG in second or third day will having status or burst suppression or burst attenuation, then it is a bad prognosis. Absence of pupillites in the second or third day is a bad prognosis. And MRI showing ischemic changes after 3 days, again it is a bad prognosis. Coming to the ARDS, what new things are emerging? So in ARDS we are mainly focusing on the supportive therapy, and that is ventilator strategies, proning, drugs, steroids, all those. This is support therapy which we are giving. The new therapies are cell therapy, which will be stem cell based or non-stem cell based or cell component based, or the targeted therapies targeting a particular pathway by the immunomodulatory or the other pathways. And the evolving these are in the clinical trials. These phases are in the clinical trials, human trials, but I think not has come in the guidelines. And the evolving is about the phenotypes of ARDS, which is leading to the personalized therapy. Depending on the phenotypes, the therapy can be tailored to that person, because it has been found that most of the therapy doesn't work in all the patients. In some it works, some it doesn't work, because of the different phenotypes of ARDS. Now coming to the mental health. Mental health is rapidly increasing in adolescent patients, and in trauma it is going to be a significant problem. They will have anxiety, they will have suicidal tendencies, they will have behavioral issues, they will come to trauma. And that's why many questionnaire has been framed so that in ED the person who is busy can rapidly assess whether the child is having suicidal tendencies, whether there is a mental issues or depression in adolescence. Okay. So I have the 5 minutes remaining. I hope I will finish in the time. And once we diagnose the mental disorders, that has to be tailored or tuned with the psychiatrist who is seen in the OPD, the ward, or in the OPDs or in the community, because that tendency will persist. And in the ER they should have the same safe place, because they can harm themselves, they can harm others, and it is going to be a core ED competency. So mental health issue has to be dealt with. Coming to the predictive medicines, we were taught to examine the child and say the current status, but now we have to predict the future also. So previously it was the path triangle which we used to follow. Now we are going for the predictive algorithm to predict suicide, predict deaths, predict CPI events, predict ICU admissions, predict sepsis, and AI is enabling us in early decision making predicting because of interpretation of X-ray and EEGs can be done bedside. Even it will help in managing the crowded Indian ER. Coming to the imaging part of emergency care, so we all know that less is more. So less radiation exposure is the current trend. The example is that Pecan has come with the new guidelines about blunt trauma in the whether to go CT or X-ray or no radiological investigations. So they narrowed down to a few points on which we have to do CT. And coming to the last but not least, so AI is going to be everywhere. In the AI, it is going to be a major role. It is a force multiplier, so it will help in clinical management. It will have in the education of the residents and the research proposals, research planning, research executions, and also will also help in hospital management. I'm not going details. I think I will stop it here only.
Thank you, Dr. Amit. It was very concise and crisp. Can you enlighten us whether pediatric emergency medicine should be a separate, or should be as a sub-speciality of the emergency medicine? What say you have on that?
I feel that if it is separate, then there will be a major logistic issue. So, with combined trauma, it is better.
So it should be combined care, but there should be training in the pediatric emergencies
definitely.
also.
Yeah,
See,
yeah.
most of the emergency medicine people are adult emergency medicine specialists, but they should have some pediatric training undergoing so that they can handle these
Yes, ma'am.
kind of patient, and vice versa also.
Yes,
I
ma'am.
think that is also required.
I agree, ma'am. I totally agree.
Right. Yeah. Yes. They are not. Yes, they are. They are. Would be required. Yeah. So some kind of special training would be required so they can handle these patients in the emergency medicine. Yeah.
Any questions from audience? I have one. Do you recommend ABG or VBG for initial sepsis assessment in trauma?
It all depends on what you want from the ABG. Many times the ABG is done for sake of doing it. If you know that what is going to be there in the ABG, just you want to confirm it, then fine. And your intervention will depend on the ABG, then it is fine. Just for sake of doing is I won't recommend. So it doesn't matter ABG or VBG. It all depends on the situation. In certain scenarios, definitely ABG is preferred, but most of the time VBG will be equally effective in decision making.
Curious that when you get adult trauma, you get so many X-rays and CT, and so a child trauma. Is it justified the same radiation and the frequency of radiation?
Ma'am, we have a panel discussion on that.
We have that, but I'm just curious, are there specific radiology machines or consoles who reduce the dose for the child?
Machine is same, but there is a dose entry is there in the settings. They do decrease the dose and the
Okay.
filter, yeah.
Okay.
In CT, yeah.
I think one of the guidelines which you mentioned regarding the peripheral IV, I think that is something which has actually been going on. You
Yeah,
know,
yeah.
we do starts the vasopressors in the peripheral, and but then it should be always a norm that as soon as possible it should be converted. We should not be very laid back. Okay, now this guidelines is there, so let's continue with the peripheral.
Ma'am,
But we should be as early as
we
possible.
we should be surprised that these guidelines come in 2026. So long it took
Yes,
to
yes.
come in.
I think most of the times I have seen, I am following the guidelines since last 20 years, so I know they take away something, then they bring back that particular thing,
Yeah.
then they bring something new and then again take it away
Yeah,
in the next
it
guideline. This
happens,
does
it
happen
happens.
because that is according to the evidence at that particular point of time.
Yes.
So then people do studies on that and then they get more evidence and then they find out that this is not so useful. Like, the drugs which have gone away,
Yeah.
vasopressin and all has not been really highlighted in this guideline. So these things are there. Thank you so much. Thanks.
Thank you for this wonderful session. I would invite the chairpersons to please felicitate Dr. Amit Kumar sir. Can I please call Alpa Patel madam to felicitate our chairpersons?
I would like to just thank the team Kemkon, team Karamsad for having me back here. Lot of nostalgia associated with this trip and with the building, seeing the new things coming up. It is a path where I had treaded and retreading again. Thank you so much to call me back here. Thank you.
Good afternoon. Has the post-lunch slump kicked in? I so hope not. We are shifting the gears now. So, emergency medicine continues to evolve at a remarkable pace, and one of the most important advancements in critical care has been the use of extracorporeal therapies. It is now my privilege to introduce the next session on extracorporeal filters in emergency medicine and ICU, a topic that bridges innovation with life-saving interventions in our next most critical ill patients. These technologies have transformed how we manage sepsis, toxin removal, multi-organ failures, offering new hope when conventional therapies have given up. I invite our esteemed speaker, Dr. Titesh Patel sir, to take us through this fascinating subject. For this session, I would like to invite Dr. Maulin Shah sir, Dr. Kinchit Parikh sir, and Dr. Dhaval Prajapati sir as chairpersons.
So thank you for giving me this opportunity. Because it is a post-lunch sedative modes session, topic is very vast, very tough to cover in 30 minutes. So I will be very crisp and be very superficial. We'll cover all the names of the filters, what is the physiology behind that, and regarding the studies, because we know that the surviving sepsis guideline has shown that it is very inconclusive. Even the studies whatever have been published, they have not shown any survival benefit. But as I always believe, something is better than nothing. So we have to know everything about that. The time will say how much it will be efficient in the future. So we'll start with the topic about the extracorporeal. So as we know that extracorporeal means something situated or occurring outside the body. So its history starts from the Turner, who removed the salicylates from the plasma of animal in the 1950s. So before we go with the topics, we should know about the molecular pathogenesis, about its characteristics of the molecules which we are trying to remove. What are the filters? Then we'll study about the role in ESRD, in sepsis, cytokine storm, in the poisoning patients, in the liver disease, and in the myeloma. So about the toxicokinetics. So about the molecular weight. So what if the molecular weight is less than 1500 dietals, it will be removed easily by the low flux dialyzers. If it is more than 1500 to 15000, it will be removed by high flux dialyzer. Between 15 to 20,000 molecular weight, it will be removed by hemodiafiltration. Beyond 20 to 50,000 by hemadsorption, and more than 50,000 by plasmapheresis. For the volume of distribution, if it is less than 1 to 2 liters per kg, then it will be easily removed by the extracorporeal therapies. More is the hydrophilicity, better is the chances of getting the extracorporeal removal. If the protein binding capacity is higher, then if it is beyond 80%, then it should be removed by hemadsorption or by plasmapheresis. Endogenous clearance. So if there is a good amount of endogenous clearance, like 4 ml per kg per minute, then there is no need of extracorporeal therapy, provided the renal function is normal. So about the small molecules. So if less than 500 Daltons, urea, creatine, and phosphorus removed easily by low flux dialysis. Mineral molecules 500 to 15,000 Daltons. We have beta microglobins, IL-8, IL-1 beta, which needs high flux dialysis. Large molecules with more than 15,000 Daltons like myoglobin, IL-10, IL-6, kappa, lambda, we have to go with the high cutoff dialysis and high flux hemofiltrations. So this is the graph about x-axis showing the protein binding capacity of the molecule and the y-axis about the molecular weight. So if the protein binding is beyond 80%, then between 80 to 90, 85%, it will be removed by hemoperfusion. Beyond if it is around 90%, that will be removed by therapeutic plasma exchange. Less than 80%, it depends all on the molecular weight. So if the molecular weight is less than 10,000, we will try with the high flux hemodialysis, and beyond that we will go with hemodiafiltration. So where and when to consider for ECTR, that is very important. So if the poisoning is likely to cause serious morbidity and mortality, then yes. If the poison is reversed by antidote, if the answer is no, then we'll continue with whether it is able to be minimized by preventing absorption and enhancing the elimination. If the answer again is no, then we have to check the endogenous clearance. If it is not high, then we have to check the volume of distribution. All this endogenous clearance and volume of distribution we can easily get in our website about the endotoxin website, where it has specifically mentioned about each molecule. Depending on the history of the patient, we'll get the ideas. And after the volume of distribution come what is the protein binding capacity of the patient, of the molecule. So if it is more than 95%, we'll go with the therapeutic plasma exchange. If it is between 80 to 95%, we'll go with the hemoperfusion. If it is less than 80%, then we'll go with the molecular weight. So 15,000 Dalton, we'll go with high flux hemodialysis. 15 to 25,000, we'll go with hemofiltration. 25 to 50,000, we go with high cutoff and medium cutoff dialysis, and more than 50,000, we'll go with the therapeutic plasma exchange. So as we know that hemodialysis is about the diffusion, so from higher concentration to lower concentration. Hemoperfusion is depending on the convection, so it is all about the solvent drag, so which we take the help of the replacement fluid. So about the heme adsorption, so adsorption means the molecule is getting adsorbed onto the surface of a either a resin or charcoal beads which we use. So the physiology is about the role of van der Waals force. So there is interaction between the electrons of one molecule with the nucleons of other molecule. There is role of ionic bonds and hydrophobic bonds as well. The filters which we use are about the dialysis filters, CRT filters, hemodiafiltration, heme adsorption, plasmapheresis. We have liver dialysis as well, that is molecular adsorbent system. Then we have FPSA, fractionated plasma separation, and we have single pass albumin dialysis and coupled plasma filtration, and we have dual plasma molecular adsorbent system. Then we have expanded dialysis, where we use high cutoff and medium cutoff dialysis, and immunoadsorption, where we use glycosope, particularly for the ABO incompatible transplant. So regarding the dialysis, we know that it is most easily available extracorporeal therapy, least expensive, and we basically use it for refractory hyperkalemia, severe metabolic acidosis, refractory fluid overload, encephalopathy, pericarditis, gastritis, and poisoning where in lithium salicylate alcohols. And it is, the filters are made from nanocontrol screen technology. Pore size for the low flux is 1.8 nanometers, for high flux it is 3.3 nanometers, and for hemodiafiltration it is 3.3 nanometers. Comparing the low flux, high flux and hemodiafiltration filters, about the clearance of the creatinine, it is almost the same. But when we go with the B12, so molecular weight for all the uremic toxins having the range of molecular weight compared with the B12, we see that in the low flux the clearance is quite lesser than that in the high flux and hemodiafiltration. So like beta 2 microglobin, other inulins, all these molecules will be lesser cleared with the low flux dialyzer. That's why we need high flux and hemodiafiltration. So this is a diagram of hemodiafiltration. So in the hemodiafiltration, we have online generated replacement fluid is generated. So inside the machine we have two endotoxin filters to generate ultra pure water. So In the first ultra filter, after the fluid getting filtered with the ultra filter 1, it bypasses the second ultra filter and gets into the dialyzer for that diffusion purpose. While the fluid which is filtered by the ultra filter 1 again gets filtered by the ultra filter 2, and that fluid removed from the ultra filter 2 is used as a replacement fluid, which will help us in convection process of the for the completing the hemodiafiltration process. So we have a convinced trial, so which has shown that there is a significant improvement in the cardiovascular and overall survival benefit is seen, and there is a better interdialytic stability, faster recovery, and reduced inflammation. Also, it has a superior benefit in avoiding hemodialysis associated amyloidosis. Demerits are that we have to wait for around 1 to 1.5 years for the cardiovascular benefit. So patient should be in continuously dialyzing with the HDF for 1 to 1.5 years. It requires ultra pure dialysate fluid, and cost is quite higher. And most important thing is the vascular access. The blood flow should be at least 500 ml per minute. Now coming with the CRRT filters, we have the surface area of 1.4 meter square, and we can use the CRRT filter for maximum up to 72 hours. And as we know, the advantage that it is a hemodynamically unstable patient we can use, and disadvantage is that the rapidity is not there. So when we want to augment the clearance of toxins in the first day, we have to go with the hemodialysis, which will be much better clearing than the CRRT. So poison clearance is 50 to 80% less than the routine dialysis. And then we come with the HA 130, that is heme adsorption 130. 130 specifically means the volume of the cartridge. So as the dialysis patient, the duration of vintage of the dialysis gets increased. 3 years of dialysis, we see 30% chances of amyloidosis in the dialysis patient, and almost 100% of the patient after 10 years of dialysis, they have amyloidosis. So to prevent this complications of dialysis, we can use HA 130. So specifically, other use of HA 30 is in the case of uremic pruritus, secondary hyperparathyroidism, also in resistant hypertension, and patient with sleep disturbance to enhance their quality of life. So based on the uremic toxins property, to improve the clearance of beta 2 microglobulin, IL-6, PTH, we use this heme adsorption. So it also enhances the intestinal microbiota. So the gut kidney axis through chronic low grade inflammation is also improved by using the HA 130. So as I discussed about HA 130, it helps in reducing the complication of uremic pruritus, bone pain due to amyloidosis, resistant hypertension, secondary hyperparathyroidism, and improves the quality of life. Now with the heme adsorption. So as we have discussed that the adsorption is based on the interaction of the adsorbate and adsorbent via the van der Waals force, ionic bonds, and it is also the filter which is made through nano scale molecular sieve technology. So it uses anticoagulant is still used in this hemoperfusion just like the dialysis, and there is no ultrafiltration, no acid base equilibrium or improvement after the hemoperfusion. So there are basically of two types: activated charcoal and resins. Now charcoal is more broad, so it can be both water and lipid soluble molecules will be clear, while from the resins we get only lipid clearance. Factors which affect the adsorption. So it is the affinity of the drug, surface area of the adsorbent, adsorptive capacity, rate of blood flow, and equilibrium rate of the drug from the peripheral tissues. Now we go with the extracorporeal treatment for the sepsis. So as we know, in the sepsis, infection is followed by immune response. So the pathogen releasing the endotoxins. So like in the gram positive we have the lipoteichoic acid, and gram negative we have the lipopolysaccharides. So they bind with the toll-like receptors onto the macrophages and increases the nuclear factor kappa beta translocations, which causes release of IL-1, IL-6, TNF alpha, and that causes contact with the endothelial cells and increases the complement pathway, causing endothelial injury, chronic low-grade inflammation and mitochondrial instability. So we have to understand the sepsis pathogenesis. So what is the rationale for using the extracorporeal therapy in sepsis? So the Claudio Ronco, one scientist, he has come with the hypothesis that is called as peak concentration hypothesis. So during the early phase of sepsis, the pro-inflammatory cytokines are released, and it causes the organ manifestation only when the pro-inflammatory cytokines has reached to beyond a toxic threshold. So the concept is that when we early remove these pro-inflammatory cytokines, it will prevent us from reaching to that toxic threshold, and that will prevent the organ dysfunction. Second theory is given by Horner and Madsen. So they have come with the theory called as the uh, threshold immunomodulation hypothesis. So whatever the cytokines are released are removed by the extracorporeal therapy, it is not just that it will decrease the cytokine blood concentration, but the fact is that inside the blood and tissue level, it will enhance the cytokine gradient, making the cytokines inside the tissues to get released into the blood, and relieving the pressure on the leukocytes and all the natural killer cells, and enhance their leukocyte chemotaxis, further preventing the cytokine cascades and salvaging the organ. So the novel strategies for the sepsis we can start is with we can remove the pathogen, we can remove the endotoxin, we can remove the cytokines. So based on the adsorption base, we have toramyxin, we have cytosorb, we have Alteco LPS, which is used in foreign countries, we have Jafron HA330. Then convection base, we have high volume hemofiltration, plasmapheresis, high cutoff membrane, and both. So both we have Oxiris, which will remove both endotoxin and cytokines. So with high volume hemofiltration, as we have already studied, that the hemofiltration process requires the replacement fluid, which is both pre and post filter replacement, which will enhance the molecule removal of both middle molecules, like which is the molecular weight of cytokines. And after that, that is done by the base of convection process. So we have coupled plasma filtration adsorption. So in the coupled plasma filtration adsorption, after the plasmapheresis, the ultrafilter of the plasma filter undergoes the sorbent cartridge adsorption. After the adsorption, that filter reaches post plasma filter tube line and is again undergoes hemofilter. So in this way we can remove the cytokines. Again, other adsorptive devices are toramycin, which has polymyxin B immobilized fibers, and HA380 is which is about styrene divinyl benzene copolymer, so it removes the cytokines. And LPS adsorber is about the endotoxin, which contains synthetic polypeptide on the polyethylene disc. So toramycin, which I have already discussed, that the duration we have to use is for 2 hours, twice 24 hours apart. Cytosorb is a divinyl benzene polymer having surface area 45,000 meter square, and it removes the cytokine molecules of up to 60,000 daltons. And in the first 24 hours we have to use it 12 hours apart. Then in the coming 3-4 days we have to use it daily to get the benefit. So it just not only removes cytokines, it can remove myoglobin, bilirubin, bile acids. Even patients who are on rivaroxaban and ticagrelor needing urgent surgery, we can use this extracorporeal filters to prevent the bleeding complications post surgery. So how to apply for cytosorb therapy in sepsis patients? So we have to go with a score that is called a cyto score. That is given by Kugelman et al. And that use the score that has to be applied 6 hours after the diagnosis of septic shock. So it uses lactate change in 6 hours, norepinephrine dose, change of norepinephrine dose after in the 6 hours time, second vasopressors, hydrocot use, and volume bolus. So when the cytoscore score at 6 hours is more than 6 points, we can go with the cytosorb therapy. And the Kugelman has showed that it reduces the mortality when it is used within 12 hours of cytosorb therapy. And there is always a time dependency. That is, every 1 hour delay of cytosorb therapy increases the odd of 56-day mortality by 1.5%. So then comes the Oxiris. So Oxiris we have 3 layers. So in the first layer we have the removal of cytokines. So the cytokine removal is done by the negative. We have AN69 membrane, which have negatively charged methylallyl sulfone. Second layer is about the endotoxin, which has polyethylene amide, which removes the endotoxin. Third layer is heparin coated, which is used for the routine dialysis purpose. So this is about the Jeffron, which has HA130, which we have discussed about the chronic dialysis complication. 230 is for the poisoning, and 330 is used for the cytokine removal, which we use in septic shock patients. Then in the Jeffron only we have other like BS30, that is BS330 is bile specific, which is used in the liver disease patient to remove bilirubin and bile acids. So so generally the charges, if we see that for toramyxin it is about 50,000, cytosop we have charge about 96,000, Jeffron is about 64,000, oxalis is 70,000. All the trials of the extracorporeal therapy have been negative, but there are certain fallacies in each of the trials. For example, in EVIOR study, where high volume hemofiltration was used, that is they used the effluent fluid of 35 ml per kg per hour versus 70 ml per kg per hour. They did not enhance the antibiotic dose into those arms where 70 ml per kg per hour substitute fluid was taken into consideration. So there were certain fallacies. Studies are in limited number of patients, so quite difficult to come to the conclusion also. Now we have other for removal of pathogens. So that is called a Seraph 100 blood filter, which have polyethylene beads with immobilized heparin bound to it. So natural physiology in the blood vessel is that in the endothelial cells we have glycocalyx, which contain heparin sulfate. So it has its capacity to bind to the bacteria and virus. So same way Seraph 100 have the cartridge in which there is polyethylene bead with heparin coating, which will remove the which will absorb the bacteria. Quite beneficial for gram positive bacteria, which has around 90 to 80% reduction compared to gram negative and virus. Now coming to the poisoning, I already discussed this slide. So about the paraquat, we know the golden hour is that coming within less than 6 hours will be much beneficial to enhance the survival rate, and we have to confirm it by urine diethionate test. And when we use the heme adsorption in patient with dialysis, we have to first use sorbent. After that the dialyzer filter will be connected. Now coming to plasmapheresis. So we have two types of mode, that is centrifugation and membrane filtration. So centrifugation is by centrifugal force and membrane filtration is by convection. Centrifugation has a greater amount of plasma extraction, that is around 80%. And we have three types. High volume, where 2 to 3 fold of volume exchange is done. That means it will remove by around 85 to 95% of the molecule reduction ratio is there, compared to the standard volume, which has only 63% of molecular reduction ratio. So according to American Society of for apheresis, class 1 indication is for Guillain-Barré syndrome, myasthenia gravis, anti-GBM disease, myeloma, hyperviscosity syndrome, catastrophic APLA, post-transplant FSGS, and desensitization prior to transplant. And also in ANCA vasculitis with pulmonary hemorrhage, cryoglobulinemia, SLE with TMA, and myeloma cast nephropathy. So it is useful in mushroom poisoning. Then coming for the corporeal therapy in liver failure, according to KDIGO guideline, so when it recommends the threshold for initiating RRT should be lower when AKI is associated with multi-organ failure. So the rationale for use in the acute liver failure is hyperammonemia. It enhances the cerebral edema. So to remove the ammonia is very important to prevent the further complications of hepatic encephalopathy. So it is associated with CRRT reduces the serum ammonia level, and it improves the survival benefit in acute liver failure. And also we have seen the 50 ICU patient with acute liver failure. Most of them were paracetamol etiology, and using plasmapheresis in this patient have shown a 21-day transplant-free survival benefit around 56%, and 21-day survival benefit is around 76%, compared to those with non-conventional therapy done without plasmapheresis. So Also, it has been tried in children with rodenticide-induced hepatotoxicity. Also, it has been used in yellow phosphorus poisoning. So, where we have seen that one session of plasma done for 5 days, survival benefit is seen in 79% of patient, and 44% of patient were initially listed for liver transplantation got delisted after starting the therapeutic plasma exchange. So this is the meta-analysis about how the plasma exchange improves the survival in acute liver failure. All the studies showed favorance of the plasma exchange. So even the American Society for Apheresis for acute liver failure, they have for high volume therapeutic plasma exchange, they have given the category 1 grade 1A recommendation. For CRRT versus plasma exchange, there is no head-to-head trial. Now, in plasma exchange, we see that there is always a requirement of FFP, albumin, and in our hospital as a tertiary center, there is always a scarcity of blood products. So there is something called as dual plasma molecular adsorbent system. So what this has been showing that the plasma filters, the ultra filter of the plasma, it again passes to two cartridges. One is the plasma filter generally removes in liver failure SGPT, SGOT, GGTs, alkaline phosphatase. With the BS330, it removes bilirubin and bile acids. With HA380, it removes IL-1, IL-6 cytokines and TNF alpha. And those filters again is after the post plasma filter is again joined with the venous chamber, and so there will be no need of any albumin or FFPs. So again it has shown 28-day survival benefit, greater reduction of cytokines, and 90-day survival rate is also better than the other routine plasma exchange. So we have Mars, single pass annual dialysis, and Prometheus. They have we have studies like Relief trial is there and Helios trial is there, which has not shown any benefit in the patients with liver failure. Another characteristic is in liver failure with ascites to use ascitic fluid ultrafiltration. So where peritoneal dialysis catheter is inserted inside the peritoneal cavity, and we can join it with the ultrafiltration pump of the dialysis, where the blood and the dialysis is off and blood clamps are bypassed. So it will simply remove the ultrafilter from the peritoneal cavity, which has only a single center study, which has shown that out of 12 patients, 5 patients went off diuretics. It gained good urine output and improved the renal function. Next is expanded dialysis. That is the last topic. So median cutoff dialysis and high cutoff dialysis have pore size of around 5 to 10 nanometers. So it will remove lambda and kappa light chains much better than high flux dialyzers. So there is some study called as Remol HD study, which shows significant reduction in both the free light chains, and superior clearance increases the reduction ratio of the beta 2 microglobulin, lambda and kappa free light chains. And it can be used in myeloma, multiple myeloma with hyperviscosity syndrome having increased bleeding manifestation, with the patient having continuous headache, altered sensorium, blurring of vision. Coming with the plasma exchange for the myeloma patient with renal failure. The study has not shown any significant survival benefit, but going into the subclinical analysis of the study itself, in the arm of those patients where the plasma exchange were done, most of the patient died not because of plasmapheresis but because of the myeloma complications. So when the study was again reanalyzed, it found that 52% reduction in the dialysis dependency was found among the survivors at 6 months who were in the plasmapheresis arm. So this is the last photo about the when a patient has is undergoing ABO incompatible transplantation. So when the titers in the recipients are quite high, so we use something called as glycoswap therapy, where we do significant reduction in the antibody titers, and that requires 2 dialysis machines. So this is the final topic. And thank you for bearing me my topic. Okay, thanks.
Thank you for that insightful session, sir. May I request our chairpersons to please felicitate our speaker? Thank you, sir. May I request Dr. Amit Patel, sir, to please felicitate our chairpersons? Thank you, sir. As we move ahead, we shift from technology to responsibility.
Wonderful session, Dr. Tirthes. Is there any question related to extracorporeal therapy? If not, then I think
A very elaborate session, Tirthesh. I just want to ask you regarding your take on low volume plasma exchange in acute liver failure. High volume plasma exchange is definitely proven,
Yes, sir.
but is there any role of low volume, because we are always in
Yes,
resource
sir.
limited setting in India?
sir. Yeah.
So I think high volume requires so much
Yes, sir.
product,
Yes,
it
sir.
adds to cost,
Yes, sir.
and of
Yeah.
course toxicity
Yes, sir.
related with the
Yes, sir.
transfusion.
Sir, actually, to be very honest, these are all theoretical for me also, because I have just recently passed out. In my institute also, we use with standard volume and high volume. Low volume, I really don't have any idea about that. And because technically speaking, with the plasma pheresis, when low volume plasma is used, then considering a patient with weight of 70 kg, with 40 ml per kg, which is our standard replacement, we use 2800 ml of volume is replaced. So that removes around 63% of molecular reduction ratio. But with low volume, if we go, then the reduction ratio will be like less than 40%. Removing that with the initial sessions will again cause the rebound. So there will be only limited 1 to 2 studies I have found with low volume plasma action. But I would say that start with only standard volume. Low volume is only a limited clinical studies, and there is no any broad study analysis for that. So that is quite theoretical for me also. I have no experience for that.
Okay, thank you. Any other question?
for the practical point of view, is there any contraindication to start with any extracorporeal?
Yes, sir. So basically, when the patient has granulocytopenia, thrombocytopenia, they have considered that avoid starting cytosol therapies, and also they have used bleeding manifestations as as a relative contraindication for starting the therapies. So that needs to be considered when we start with the cytosol.
And the another way is, when we start this
Yes, sir.
extracorporeal therapy,
Yes, sir.
is there any timing of the particular
Yes,
antibiotics
sir.
or something?
Timing with the antibiotics. Sir, antibiotics specifically for the cytokine storm, when we start, as we have the study done by Kugelman, he has told to start with after 6 hours analysis of sepsis. So with the early 6 hours, we have to always focus on our standard therapies. After 6 hours, our conventional therapies are not giving us the beneficial result, then only we can go with the with the extracorporeal therapies. And after that, for example, if you want to start the extracorporeal therapy with high volume exchange, then always start with standard dose of antibiotics, despite whether the renal function is like less than 10 ml GFR or more. We have to give the standard antibiotics and go with the extracorporeal therapy. That's what I personally believe. For example, what we do in the CRRT patients, like we start with the higher dose of normal dose adult patient antibiotics we start. That's
Thank
we
you.
have to consider.
Thank you.
Yes.
Thank you, Dr. Devis.
Yes.
As we move ahead, we shift from technology to responsibility. Because with great power in medicine comes an even greater need for ethical judgment. Our next segment is a panel discussion on radiation, ethics, and consent in children and pregnant females in emergency medicine. This is an area where clinical urgency often intersects with ethical dilemmas. Balancing diagnostic necessity with patient safety, especially in vulnerable populations, requires not only knowledge but wisdom and compassion. We are fortunate to have an esteemed panel of experts who will share their perspectives, experiences, and practical guidance on navigating these complex situations. I now invite our respected panelists, Dr. Shibashish Bhattacharji sir, Dr. Rumi Bhattacharji ma'am, Dr. Amit Patel sir. May I request our moderator, Dr. Keur Shah sir, and our esteemed chairpersons, Dr. Sapna Gupta ma'am and Dr. Amit Kumar sir, to please take their seats.
Good afternoon. So Dr. Abhishek Sharma sir is not here. That's the reason why I'll be taking care of this session. This topic is honestly most important for us because we regularly see such patients, a pregnant female with RTA, and we want to do X-ray, we want to do CT scan, but then we are worried about the baby. More than the mother, we are more worried about the baby, the radiation and all the legal factors. Recently, we also had a perimortem CS patient, a true case where we had to take a call. So I would start few questions. So first with Amit sir. In an emergency situation where an immediate imaging is necessary. Sorry, I'm not going to show the case. I'll just read. In an emergency situation where an immediate imaging is needed, but the relatives, they refuse to give consent due to a radiation fear in a pregnant female, what is the legal and ethical standing of a doctor, especially in trauma as well as in the ortho?
Okay, thank you for giving me easy one. Thanks. Okay, now consent in a pregnant woman. She's an adult. Okay, I think practically across the board we take informed consent, but who signs it? Usually it is the relative. I mean, if the residents around here, are the relatives who signs your consents? Relatives, am I correct?
Yes.
Okay. So that is wrong basically. The Supreme Court, there's this Manchanda versus Kohli or something, Dr. Manchanda versus Kohli. I think that is a female who was taken up for you're actually this thing. She's a gynecologist. She was taken up for laparoscopy, and then they did a hysterectomy because they told, we're already there and we'll do it. Okay, yeah, I have some support here.
Yes.
So it was ruled against Dr. Manchanda because consent for hysterectomy was not taken from the patient. बाहर जाके रिलेटिव बोल गया भाई आओ पेशेंट बहुत सीरियस है आओ करवू पड़से, that doesn't hold in court. So consent has to be taken from the patient. The patient has to consent unless there are 2 or 3 conditions: the child or the patient is unconscious or is mentally unsound and not capable of signing the consent paper. So here I think straight away pregnant patient, obviously she is going to be an adult, so the patient needs to sign it. Okay. In India, the scenario is a little difficult. We have to look at the social part of it as well. So I think we have to involve the relatives, take the patient's consent so we are safe. Kuch bhi ho jaye to we are safe. But we always have to involve the relatives, take the signatures as witnesses. And I think, it's more than giving them scientific details. This is the probability of, one pelvis X-ray or one chest X-ray causing this much damage. I think they won't understand anything. So we have to sort of put it in a way that you have said that it will, have some increased risk of cancer or blah, 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 whatever, put it very mildly. But I think usually they'll come around to signing it.
Sir, I'll twist it again. If the patient wants to do, like she doesn't want to get a CT scan or an X-ray done, but the husband says, no, she is more important, she is not in a good sense, please do whatever is needed, save my wife.
If the patient says no, I think you have my answer already.
Correct.
I would spend a lot of time with the patient and trying to convince her, but if the patient says no, it's a no.
So I completely agree. It's the mental capacity we need to check, and if it is intact, the patient holds the complete right, and whatever they say, we need to do it. So true. Ma'am, the next question. Now, how should we consent by taking in such a high pressure, like in ER or in the, like we will be of course calling an obstetric team as well, with the minimum essential elements to both protect the patient as well as to us. In the consent, if we are taking from the patient or from the relative, depends on the situation, what all minimum points needs to be mentioned on that, so that if in the later case someone else wants to put a medico legal problem,
In which context?
same this is the same patient, a female, pregnant female, young, maybe just 8 weeks old, pregnant, and she has come with a road traffic accident where we are expecting multiple fractures. With this, we are also expecting that because the organogenesis is still ongoing, the radiation will become a trouble. We explain to the mother says no, but the husband says please do it. There we explained it, but what all minimal points we should mention on our paper, so that in the court, if we are being asked, those minimum points will safeguard us.
See, according to the doctrine of necessity, what is necessary we have to do. So no court will save us if we do not do what is required in that situation for that patient. Now, if the patient is only 8 weeks, so there is a minimal risk of danger. So if you want to do a CT head, that will not cause any problem to the fetus. Okay, but if she requires a CT abdomen or CT pelvis, then also it is said that more than 15 rats there is a risk of damage to the fetus. So we usually use less than 5 rats.
Yes.
So 1 rad is equal to 1000 millirads. So it's a very minimum dose. So these doses do not cause any harm to the fetus. There's a theoretical risk of 1 in 1000 of that unborn child of getting a cancer in his lifetime if he is born. So we have to take our regular consents, whatever we take, and we have to do what is necessary. Now there is one more thing. If now this is only 8 weeks, like if the patient is around say 36 weeks or 38 weeks, in which the fetus is salvageable, and then there is a intervention which might, which is not done and which might pose a danger to the fetus, in that case her permission alone is not valid, because now we have to take into consideration the survival of the fetus also, because the fetus has a right to live.
True.
So in the US and all, there are so many things we don't have in India, so even the court is invoked in that case. Okay.
Exactly. Sir, the next question is for you. In an hemodynamically unstable trauma patient who is either pregnant or a child, how do you justify immediate CT scan despite radiation risk? Where do you draw the line between life-saving and a potential harm?
In a hemodynamically unstable patient, I will not ask for a CT scan. I would ask for the patient to be resuscitated first. In any case, let us say that we get a CT scan done. She is in shock. He or she is in shock, and it shows a large extradural hematoma. You cannot take the patient to the OT. Patient is going to die on table. So, if you think from the treatment perspective, the hemodynamic stability is more important. Second, head injuries per se do not cause hemodynamic instability. Hemodynamic instability is maybe because of an abdominal injury, a chest injury, a long bone injury, and you have to find out that source and treat that first to stop the hemorrhage, so that you can make the patient hemodynamically stable, and then we can do the CT. So in that period of time, it is possible that the patient may deteriorate, but that is the risk we have to take, because in anyways, doing an extradural hematoma, removing an extradural hematoma will not still save the life of the patient. So bringing the patient to hemodynamic stability is more important.
So then in this, if a patient relative tells us that if you don't operate, this patient can even be a brain dead, so should we even explain those points?
You are in charge, you decide, you guide, you are the pilot. Relatives, sometimes there might be some troublesome relatives who would come with all these things, but I think in the end it's your decision, and they cannot dictate the treatment.
So the doctors really play a vital role in taking a decision if they really want to get a CT scan done, or they first want to take a call of stabilizing the patient. Sir, to the Amit sir now. What are the actual quantified risk of radiation to a fetus or a child in trauma imaging, like a CT scan or maybe a PAT CT, like PAN CT, and how can a clinician communicate the risk in a simple terms to the relatives, so that they understand the risk is minimal or what is beneficial to them?
We have to tell that to the person, to the relatives of the child, that city is not going to do that harm as crossing the road. So traffic is more harmful than the city, because risk is 1 in 1,000 in CT scan. Even if you do repeat CT also, the risk is still very low. And in layman term, and the benefit of not doing CT should be explained, that the cost of not doing CT may be more harmful, because the surgeon may not be knowing what he is going to do in the OT, or the treating person may not be doing how to handle further. So that may hamper the life immediately, versus 1 in 1,000 risk.
So we can say that the risk is quite low, and we should try more towards the getting a CT scan if it is a much needed. I think we should get, and the risk of cancer or any other stuff can be dealt later on. Ma'am, again one more question. In a pregnant trauma patient, is fetal risk from radiation truly significant, or is maternal instability a bigger threat? How should an emergency person prioritize this?
So as I have already told you, the risk, the doses is very low. The amount of dose we use for CT scans, and a single use CT scan is not going to cause any harm. I already told you, the theoretical risk is 1 in 1,000, or some people say, even some literatures quote 1 in 3,000 of the child having leukemia in future. So, however, the life of the fetus depends upon the life of the mother. So, if the mother is unstable, the fetus is anyway not going to be stable, and the fetus is going to become more hypoxic much before the mother. Okay, so you have to explain to the patient and the relatives that the withholding intervention or diagnostic procedure is more harmful than doing nothing.
So, ma'am, I will continue this. So, if I have a such type of patient, and now there is a cardiac arrest,
Okay.
and in this cardiac arrest, for 2 minutes we have given CPR, but the chances of ROSC was not seen, and that's the time the ER team has called our anesthetist, pediatrician, as well as our obstetrician, and they want to go for even a perimortem hysterotomy. Should we get a consent for this?
No, we do not need a consent for this. Again, the doctrine of necessity will be applicable here. So we can go ahead. Even if the patient relatives refuse, still we can go ahead, if we think that this procedure is in the best interest of the patient.
So here, ma'am, are we trying to save the baby, or is it the mother?
Mostly the mother.
So it's not the kid, it's the mother.
So if we remove the fetus from the mother, it will relieve the aortocaval pressure, and so the emergency team will be more equipped to resuscitate the patient.
Oh, I'll continue this.
Okay.
If we deliver a baby, the baby is alive.
Okay.
Now the parents are not ready to accept it, like the father, and the mother is dead.
Okay.
How can we move ahead?
So we have to resuscitate the baby.
No, the baby is fine.
Okay.
The baby is fine.
Okay.
Mother, we couldn't get an ROSC
Okay.
achieved.
Okay.
Finally, we tried all our hard work, but the resuscitation was not fruitful. The mother died. The baby was out. We gave this baby to a father, and the father is not ready to accept it, saying it, I am just 19 years old, let the child die. It's a true scenario.
Is it? Okay. See, I believe that now we will have to involve the trauma counselors. We need a separate team now to handle this type of family conflict. But from our side, we will of course try to counsel the patient. Okay, and we will tell him if we know of any support systems, if we are aware of, then we may help guide him towards those support systems. Okay.
Yes, ma'am.
But
Actually,
for the time being, if he is not taking the child home, we have to give it to the pediatrician.
the real answer is true what ma'am said, that even if you have delivered the baby and the mother expires, the father or the family is not ready to accept the child, we have to continue the care. Once the baby is stable enough, everything seems okay, then there are a lot of authorities who handle this. Like even over here, we can even send them to the orphanage. There are so many other families who need a kid and there are trouble. So the government of India has also said that save the baby, save life, don't think about who will take care of it. There are a lot of other government bodies who will take care of it. So coming to trauma. Patient has a femur fracture. She is pregnant. She is a 32-year-old female. She had a fracture in the femur, and because of this, she didn't opt for an operation theater, like for the OT which you had suggested. She was bedridden. After 10 days, now this patient is breathless. You are still suspecting that it's a pulmonary embolism or a fat embolism. So, what are your plans? Do we want to treat the ortho part or just?
No, no. I mean, 10 days, if there's a fat embolism, whatever, I think the patient will need intensive care. So I think then that is not an issue at all. Over to the, ICU chaps and the obstetricians. Because it's 10 days gone. Usually by 10 days, if they have, probably they would already have developed a fat embolism by then. They're probably on the way, getting better. So once they start getting better, we just treat the femur non-operatively. She's already taken a decision. She's the best time for operating on her is gone. She's now used to it. Whatever the worst complication that can occur has occurred. So I think we are past it already. I think then it's just a question of let her get better. They do heal conservatively. It's not seen these days, but in the 70s and 80s, we used to treat patients conservatively. They used to heal, maybe a little malunion, but they used to heal. So that's not an issue.
Any questions from our audience or from our faculties who are here, who has seen few difficult cases and want to get an expert opinion?
Management. Husband didn't came back, so we informed RMO and took the consent from RMO and cesarean section started. After completing of cesarean section, suddenly the husband came, and the gynec resident shouted to him, "Where you were?" He answered, "Okay, I had to get the case, so I went for collecting the money, 30 rupees, to get the case." So these are the scenarios also. So at that time we have to consider that. But in that case, as Kevur sir has told, husband was not ready to accept the child. He left the hospital without informing anyone. Then what to do with that newborn baby?
So the answer is still the same, ma'am.
Should we inform the police at that time, or should we inform any other NGOs or something like that?
The police will always be involved, ma'am. I completely agree, ma'am. To best of my knowledge, maybe within this 6 months, we had a similar case where we were delivering, like patient had been as a broad dead, or maybe we were giving pulseless electrical activity. We started CPR. After 2 or 3 minutes, we realized that okay, she is a pregnant female. We need to do perimortem hysterectomy. We prepared everything. Suddenly, a word came up. Consent liya kya? And that's the time when we stopped. Should we or should we not? We had no clue. We tried our level best. We went to the relatives. The relatives were not ready to give any consent. I think the uncle was there. The uncle told us, "Agar maro jamai nathi karto, હું કહેવાથી એનું risk લઈ શકું છું." And the husband was just 18 or 19-year-old, so he couldn't even take any decision. By the time they took a decision, the answer was no, and even the fetal heart rate was 0. So we lost our baby. We had a word with the forensic team, and that's where we learned, and that was why yesterday there was one topic in the workshop. that life is most important. Don't think about the rules and regulation in terms of legality. If the patient is conscious, they have all the rights. Otherwise, the doctor can take all the decisions to save that life, and don't wait for any other relatives. So if they deny upfrontly, still the call is not of the relatives, it is of the doctor, and the doctor has to do the process, whatever safeguards the patient. This we are not doing it for the baby, we are doing it for the mother. So to safeguard mother, if a hysterectomy is required, I mean to say perimortem hysterectomy, then we should do it. We should not think about any other consequences. If the baby survives, very good. If it doesn't, still it is fine. This whole process we are doing it only for the mother. So sir, there is a counter question to it. If there is a tension pneumothorax and the relative says don't put a needle, but we are still gonna do it. So this is the same answer, that to safeguard. Yes, and emergency, in emergency we have to do. So if there is a life saving thing is in emergency, where this emergency decision has to be made, it has to be done. If the baby survives, police case needs to be done, then this case needs to be given to the police, but we take care of the baby till the police is doing all the other further paperwork. Yes sir, yes sir. So even if the relatives are there, do the correct thing. That's the answer.
Actually, in the US, 2 cases have been documented in which cases lawsuits were filed against doctors for not performing perimortem cesarean section timely. So no case has been levied against doctors for performing the procedure.
Any further questions?
You have to explain the risk, na? Risk of severe morbidity and mortality. You have to explain before the procedure. That there is perhaps 5-10%. Even if there is a 10% chance of survival, then we should go ahead.
In fact, the recent papers have also shown that it is not 4 minutes. Even the babies are alive after 9 minutes.
Even
I'm not trying to extend those
minutes.
time.
Even 30 minutes.
30 minutes. So the point is, you should do it. That is more important than any other problem. The rest of the problems will be easily tackled by police, and they are with you. Yes, yes.
I think, to put it simply, any procedure done to save a life in an emergency situation is justified. Worst to come, even if you go to court, there is going to be an expert witness. And who's going to be the expert witness?
A doctor.
Another doctor.
Yes.
It'll be the same thinking. Huh? Sorry?
हाँ कैमरा होता है, पर मैम कैमरा का पीछे अभी भी डॉक्टर ही है.
हाँ कैमरा होता है, so what?
Documentation.
हाँ हाँ ओके. नहीं इन इमरजेंसी सिचुएशन कितना डॉक्यूमेंटेशन क्या करोगे? I think you meant an emergency life saving situation. We have to go for life.
For life. That's the point. Even we made a mistake just because of that consent. We stopped, and that was one of the mistakes which we never wanted our team to further do it. So we wanted this discussion. Thank you so much.
May I request our chairpersons to please felicitate our panelists? Thank you. That was a thought-provoking discussion. Up next is an exciting and intellectually stimulating Golden Hour quiz competition. A perfect blend of learning and fun. This is your opportunity to test your knowledge, challenge your peers, and celebrate the spirit of emergency medicine. May the best minds shine. I now request the chairpersons for this session, Dr. Harsh Patel sir, Dr. Rushabh Mehta sir, and Dr. Kushal Vekaria to please take their seats. And I introduce our quiz masters, Dr. Alisha Akhani and Dr. Jaina. A big round of applause. Louder, guys. Thank you. Just a moment, we would like to felicitate our fellow emergency physician. May I request Dr. Keur Shah sir to please felicitate Dr. Mittal ma'am. Thank you. Over to the quiz masters.
Hi, good afternoon everyone. We are towards the end of today's session. Are all the teams here? Okay, so I see one team. So there's one team, Shant, Mohit and Arpita. Are they here? Okay, can you please come in the front rows? Another team for Janvi, Rutam and Saumil. Can you please take a seat in the front rows? Dr. Umang and Dr. Asmita. Just come in the front row so that it's easier for you to come on the stage. So before we start our quiz, we would like to feed you. So tea and snacks are ready. Let's quickly circle back in 10 minutes. Thank you. Team we have Rishant, Mohit and Arpita. Third team, I think there is Dr. Umang and Dr. Asmita. Are they here? Okay, perfect. Fourth team is EMI Alliance. You are free to name your teams as our department's residents have. That would be the fourth team. Fifth team is Kia. Sixth team is Vishakha and team. Am I missing any teams? Oh, sorry. Seventh team is Pallav and who are your team members?
Hemiksha and Vanshika.
Who? Hemiksha and Vanshika. Okay. Okay, sounds good. Are you going to consent? Do we have your consent? Yes. Okay, so I'm going to explain the rules first. We have 3 rounds in this quiz. First round is rapid response, which will be a rapid fire round. Every team will come on the hot seat and you will each have 2 minutes of time to answer 10 questions. These 10 questions are one-liners, they are straight shooter answers, so try to answer as precisely, as clearly as possible. Mechanism of some drugs would be asked, some ECG, so it's a mix of all the questions. So you will have 120 seconds to answer 10 questions. There is no negative marking in this round. Whoever answers the most questions and whoever takes the least amount of time to answer will proceed in the second round. The second round is buzzer battle, where we have, well, you'll see where we have a lot of questions, spot diagnosis questions. However, there will be negative marking in the second round, so raise your hands only if you're absolutely sure of the answer. And third is the cricket challenge. Now that's a surprise. It is the toughest round till date. A lot of faculties, including Dr. Darshan, has personally curated these questions. So I hope you enjoy it. For our first round, let us start with the new intern doctors. So sorry, the new doctors, Dr. Janvi, Dr. Saumil and Dr. Rutam. These are some rules. We have our moderators, Dr. Kushal, Dr. Harsh and Dr. Rushabh. There is no whispering or chattering allowed. Any answers from the audience or any answers within yourselves will lead to immediate disqualification. In case of ambiguity, Dr. Darshan Shah will be the deciding faculty of the answer. Answers must be clear and specific and there is no negative marking. Okay, these are the rules that I have already said. 2 minutes to answer. Yes, one thing I forgot to mention is you can skip the questions and come back to it. So if you're not sure, if you're confused, you can just say skip and you can come back. Can you please check if that mic is working? Okay, it is working. Fine. For our team 1, can you please click on the timer when I go to the next slide? Okay. Question 1.
Adrenaline.
Okay, question 2. Yes?
Pass.
Okay, next. Interpret the ABG, please. Next.
Pallid.
Okay, next. No whispering from the audience, please. Keep your enthusiastic answers to yourselves.
Right lung consolidation.
Okay, next.
Colis.
Speak loudly, please. Okay. 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 Thank you for playing this round. You have one more question which you passed. Would you like to go back to it? You have 10 seconds remaining.
Stop.
Stop? Okay. All right. For team 2, I would like to invite Hia and team. Okay, if you're confused, please say pass, please say loudly. We are not able to hear you. Okay, this is not yours. Fine. Ready? Can we start? Let's go.
Pass.
Anesthesias with benzodiazepines.
Next.
Pass.
Interpret the ABG, please.
Alkalosis.
Next. Be a little specific. Be specific in your answers.
Metabolic alkalosis.
Next. Next.
Pass. Axillary nerve.
Next.
Green.
Next.
Pass.
Do you want to go back to your previous questions?
Yes, ma'am.
Okay, let's start from the beginning.
Next. Next.
Stop. Okay, thank you so much for playing. Give them a round of applause. They are still second year MBBS students. Okay, now for team 3, I would like to call EMI Alliance, Dr. Vijay, Dr. Ravi and Dr. Dhruvil. Please make sure you're heard, just the same way you're heard in the trauma. Okay. Okay, ready? Let's go.
Atropine. Septic. Infero-posterior.
Identify the ABG.
Metabolic acidosis.
Next.
Lumazenil.
Next. Be specific in your answers.
Right-sided pleural effusion.
Next.
Garden spade deformity.
Next.
Green.
Next.
Osmotic demyelination syndrome.
Next.
Atropine.
Okay. Okay, they are done. Okay. Well played. For team 4, I would like to call Arpita, Dishant and Mohit. Mohit. Okay, be specific as much as possible. Okay, fine. Ready? Shall we go? Question 1.
Dorsalistic. Magnesium sulfate.
Next.
Crow.
Next.
Atrial flutter 3:1.
Next. Interpret the ABG.
Metabolic alkalosis.
Next.
Naloxone.
Next.
Bat wing appearance, pulmonary edema or ARDS.
Next.
Posterior hip dislocation.
Next.
Mortality. Death.
Sorry.
Mortality.
Next.
Hyperkalemia. Severe.
Last.
Hypovolemic shock.
Okay. Thank you for playing. Okay. Next, we would like to call Dr. Umang and Dr. Asmita. Ready? Alright. Let's go.
Benzodiazepine.
Specific answers. Okay, next.
Aspiogen.
Next.
Pass.
Interpret the ABC.
Metabolic acidosis. Pass. Left side pleural effusion.
You're asking for a sign. Okay, let's go to next. Pass?
Pass.
Okay.
Pass.
Pass?
30 seconds.
Hyperkin.
Okay. Last.
Stop.
Done. We're done with time. Thank you. Thank you so much for playing. Okay. Can we have the surgery team? Team surgery with full consent. This is what on-spot registration looks like, guys. Okay, ready? Be precise, be clear in your answers. Shall we start? Question 1.
Adrenaline.
Next. Next.
Pass.
Interpret this ABG. Sorry? Be confident. Respiratory issue. Okay.
Respiratory acidosis.
Oh, respiratory acidosis. Okay. Okay.
Cardiac.
Okay.
Radial now.
Next. Please be silent in the back.
Pass.
Pass.
Potassium.
Okay, next. This is the last question.
30 seconds.
Pass. Would you like to go back to your ECG questions? No. Okay, thank you so much for playing. Please give them a round of applause. Okay. Can we have Dr. Vishakha and team on stage, please? Take the mic, be loud, be specific, so we can all hear. All right, shall we start?
NMDA block.
Interpret this ABG.
Respiratory acidosis.
Next.
Alkalosis.
Pass.
Left upper zone haziness present.
Next. Please no murmuring.
Right side neck of femur fracture.
Complication is asked.
Avascular necrosis.
Next.
Red tag.
Next.
30 seconds. Hypokalemia.
Next.
Parkinson.
Do you want to go back to your past questions? Okay.
Stop.
Okay. Thank you so much for playing. This is end of round. Okay. Can we please have Pallav, Hamiksha and Vanshika for our next round? You are ready? It's okay. There is no wrong answers. Okay?
I agree.
All right.
Atropine. Hemorrhagic. Anterolateral.
Interpret this ABG.
Metabolic acidosis. Atropine. Pass.
Okay. Which nerve is affected by this fracture? Pass?
Pass. Red.
Okay.
Calcium.
Next.
Pass.
You have time left? Do you want to go back to your past questions? Hint, this is first year MBBS. Pass? Okay. All right. You want to go back to any? No?
Stop.
Okay. Thank you so much. Team Atropine, everyone. Okay. Are there any more teams remaining to play the first round? I think Keusa wants to play another round. Should we have one round for our faculty? One rapid fire round for our faculty. It's okay, we have so many departments. Somebody should know the right answer. Ignore the number. Please keep your answers very specific and to the point. You are ready? Let's go. Okay. 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 Interpret this ABG. Okay. Okay, next. Okay, thank you. Okay, so we are going to take 4 teams in round 2. So we have our results for round 2. Dishant and team, Avi and team, surgery and team, team Atropine, and LG people. I'm sorry, I don't know your name, but I figured that you are from LG. Sorry? Darshan. Okay. So we are going to have team numbers. The first team will be Dishant and team. Okay. The second team will be EMI Alliance, that is Dhruvil, Vijay and Avi. The third team will be surgery. Will you remember your team numbers? And fourth team will be Dr. Darshan and team. Okay. The next round is buzzer round.
Moving on to round 2. Can we have your official name, team name? Team name, just a team name.
Team 1, team 2, team 3 and team 4. Okay? I know you guys have a team. Fine.
So the second round is spot diagnosis round. You will given a case-based slide. You see it, you raise your hand. The first person to raise the hand will get a chance. But you will have only 1 minute to guess the answer. If you don't give answer within 1 minute, you will get the negative markings. There is negative markings. You will get negative markings If you give an answer wrong, you will get a negative marking. If you raise your hand, if you don't know the answer, if you are unable to answer, you will get a negative marking in this.
There's no 1 minute, okay? So only raise your hands once you're absolutely sure of the diagnosis. In 10 seconds, they have to answer. Yes. They will not take time.
No. You will get approximately 1 mark.
Plus 1 mark for every right answer and minus 1 mark for every wrong answer.
Wrong answer.
Sorry. That's what we are going to get. Sorry. We got that. Okay.
For the sample question, this is how your slide will look like for the case. You will have, over here you will have a primary survey with the patient's vitals. You will have the focused history of the patient. You will have the investigation, and over here you might have a visual clue like X-ray, ECG, CT scan or any visual images of any clinical disease. Okay? And then you have to diagnose it. What is the diagnosis? What is the clinical picture? Any doubt?
Are you able to see the screen properly? Is it visible to everyone?
Is it visible? Okay. Any doubt in this? So just the orientation of the slide. Primary survey, there will be a focused history, there will be investigations, and there will be X-ray, CT scan, anything of related to the case. You have to take the clue and then you have to do the diagnosis. Moving to this, we are starting the quiz, okay? Okay. Next one. Team 4. Okay. That's it. Team 2. Okay.
Please be specific in your answers.
Yes. Be specific. Team 4. Okay. Okay. Can you be specific little? Okay. Next question. Team.
No, that's the wrong answer. Any other team?
Yes. Team 2. Okay. Team 1. Anyone wants to try? Team 4. No. Team. Kemkon syndrome. Next. Team 2.
Please answer loudly.
Team 1. No.
Hemolysis syndrome.
Let's move on. Next question. Team 1. Next question. Okay. Can we move to next question? Next question. Next question. Please be specific. Which meningitis? Next, can we move to the next question? I repeat, be specific. Can we move to the next question? Can we move to the next? Can we move to the next question? Team 4. Moving to the next question. So we are at the. Okay. So the answer of this question is acute inferior wall MI. The answer of this question is these small bowel the tension pneumothorax. The small bowel obstruction with this is ruptured ectopic. This is left hyperdense MCA sign, so it is an acute ischemic stroke. This is the opioid overdose. This is the septic shock. This is the compartment syndrome. This is the DKA. Then this is the febrile neutropenia. This is Steven-Johnson syndrome. This is acute epiglottitis. This is ureteric calculi, HELLP syndrome, meningococcal meningitis, thyroid storm, DIC, pulmonary embolism, intracranial hemorrhage, and adrenal crisis.
So for round 3, two teams will be eliminated. Can we have guesses on one team which is going to definitely be eliminated? Team Surgery, we applaud you and thank you for playing with so much spirit today. You played the first round really well, so much spirit. Thank you so much for joining us. We have a tie between two teams, and there is one team which is definitely going to the third round. That is Team 1 with the highest score in round 2. We have a tie between PSMC and I think you are all from LG, right? So we have a tie between PSMC and LG. So we will be playing a tiebreaker round to decide who goes to round 3. Team 1, can you please for some time take a seat behind? I would request Team 4 to come in the middle. Make yourselves comfortable. Okay, sorry for the delay. For the tiebreaker, we have again rapid fire questions based on ACLS algorithm. I hope that is the bread and butter of emergency medicine. So our scorekeepers are ready. Okay, I have the answers with me. Sorry, what? Direct. No. Hand raise. Just raise your hands. Sure, I will. Okay, shall we go? We have Avi and team and Darshan and team. Okay? Rishabh sir, Harsh sir, are we ready? Avi and Darshan. Okay. First question is, what is the gold standard for confirming ET tube placement? Team 1 na bolo please. Avi or Sorry? More specific? They raise their hands first. Sir, please upa raho na. Sir, અહીંયા ઉભા રહો ને please. Thank you, ma'am. Okay, we'll let go of that question because there was some confusion. Okay. ET CO2 capnography would be the correct answer. ET capnography. Fine. We will let go of that. We will disregard of that question. Okay, fine. We will disregard. There's no points for that answer. Okay? You are still 0-0 at this point. Okay. What is the preferred current site for needle decompression? Correct. That is correct. Okay. Question number 2. Question number 2. What is the drug given after third shock in VF? Yes. Dose. Correct. And point goes to this team. Yeah. So it is one each. Okay. Please don't half raise your hands, please. It is only going to create more confusion. Okay? Fine. But मैम ये बच्चे उभा रहे तो खबर पड़ते ना. Okay. Okay. What is the targeted temperature in post-cardiac care?
32 to 36.
30?
2 to 36 on Celsius.
Correct. I think we are at the end of our tiebreaker. Avi and team win. Okay, without further ado, let's quickly start round 3. Can please Dishant and team join us? Okay. So round 3 is cricket challenge. Okay, look alive everyone. Sorry for the delay. Fine. Can we have a round of applause for the 2 final teams? A big round of applause. Thank you so much. Thank you so much. There is no rapid fire. There is only MCQs, and each team will play a decided 6 questions. Okay. So let's start with our. So the last question is not an MCQ, but again it's a very objective question. All the parts of that question has to be answered. All the parts of that question has to be answered for you to score 6 points. Okay, so each team will play 1 over. Each ball will carry different runs with a total of its 19 runs, not 20 runs. Team with maximum runs will win in the end.
Hello.
Okay. Alright, so this will be our team 1 and this will be our team 2. Okay? Judges, team 1 and team 2. Okay. You will get 60 seconds to answer each question. For last 6 runs, you will get 90 seconds to answer. Okay? Timer, Helena, you ready? Okay, 60-second timer. Fine. Is team 1 ready? It's an MCQ, so please let us know your answer. Question 1. There's no negative marking. नहीं, it's not a either or. एक का team માટે છે. બધા questions ખાલી team 1 માટે છે.
Are we early diastolic collapse?
Are we early diastolic collapse? That is the correct answer. You have scored 1 run. Let's go to second. Yes. I'll start with the next one. Helena, can you please let us know when there's only 10 seconds remaining? Thank you.
Right abdominal surgery.
I'm sorry, Dr. Dishant. The correct answer would be suspicion of bladder infection. It is not a contraindication. Okay. Are you ready to play the third ball? Here it goes. Please let us know any answer.
Placement of rigid eye shield resting on orbital bones.
I'm sorry, that would be the wrong question. The absolute contraindication is Goldman applanation tonometry because you're not supposed to apply pressure, any kind of pressure. Anyways, निराश होने के बजाय चौथा गेंद. This is a 2-slide question, so please quickly go through the first one and I'll go to the second slide. Second slide. Which of the following is the most likely etiology of this patient's acute kidney injury? Yes.
Atheroembolic renal disease.
That's correct for 4 runs. That is the correct answer. Let's go to the next one.
phentolamine.
I'm sorry, that would be the wrong answer. The correct answer is diazepam. Okay, now for the last ball, sixth ball, you get 90 seconds. So please take your time. You have to name the criteria and also tell the details of the criteria.
Something related to Ottawa.
You are correct, it is Ottawa knee rule, but unfortunately for you to score the whole 6 runs, you will need to say the criteria.
Unable to take 4 steps.
That's yes. Okay.
Tenderness at the
Okay. For our audience, the correct answer here is Ottawa knee rule. It has 5 points. First is age more than 55 years. Second is isolated patella tenderness, that's what you were thinking. Third is tenderness at head of fibula. Fourth is inability to flex knee at 90 degrees. And the last but not the least, what he said is inability to bear weight, which means cannot walk for more than 4 steps immediately. If any of these conditions is present, then yes, an X-ray is warranted in emergency or acute settings. Thank you so much. Can we please have the total runs per team? 1. Everyone please give a huge applause for scoring 5 runs to team 1. Okay. Is team 2 ready? Okay. Fine. Can we have the timer started? Let's go for first ball for 1 run.
C. The modified GCS scale should be used at those age less than 8.
That is correct. The modified GCS scale should be used in those age less than 6 years and not 8 years. That is the correct answer. Let's go to the next one. Which of the following reflexes has been linked to the wrong nerve roots? Please no murmuring.
D.
Knee and L2, that is correct. Knee is L3, L4. Okay. Third ball, there's 2 slides. So let me know when you want me to change the slides.
24 hours urine arsenic level, D.
That is correct. And that is 4 more runs. Okay, for the fourth ball.
Surgical tubectomy to create new, D.
I'm sorry, that would be the wrong choice. The right choice is laser peripheral iridotomy to create a bypass for aqueous humor flow. Don't be disheartened, you still have 2 more balls to play. Next.
C.
That is correct. Total score of less than 10 is not low risk, but it is high risk of mortality. Okay. And the last home run or chakka. You have to name the criteria.
Pharyngitis na criteria આવે છે, criteria.
Meningitis?
Pharyngitis માટેના જ છે 4 criteria.
No, there is a name. Done, are we done with time? Okay. The answer to this question is centaur criteria. But do you know the contents? Modified or Mac-Isaac centaur criteria is used for our audience. So if the age is if the age of the patient is between 3 to 14 years, you give 1 point. Tonsillar swelling or X-ray is 1 point. Tender or swollen anterior cervical lymph nodes, that is 1 point. A temperature of more than 100.4 degrees Fahrenheit or more than 38 degrees Celsius, that is 1 point. An absence of cough is 1 point. If there is more than 2 points, then gas, that is group A streptococcus, is more likely. That is the centaur criteria which is used in pediatric patients. Our moderators, would you please like to come up on stage and announce the winner of our quiz? Can we give a good round of applause for team 1 and team 2?
I hope everybody has enjoyed the quiz. Our teams have played really well. Out of these two, second prize goes to Dishan's team.
So the first So the winner of the quiz will be a team from the emergency department of our college itself, PSMC Medical College. Avi, Ruvil and Vijay.
દેખાતું નહીં.
I would like to request Dr. Harsh Patel sir to felicitate Dr. Mihir sir. I would like to invite Dr. Bhalendu Vaishnav sir for his session.
Hello. Hello.
Talk a little about Court Krishna. Those who are here, they already know. It will be a very brief, but I believe it would be an important message at the end of this very excellent conference. So, just look at this photograph. Very quietly, all of you think fast and act fast. That was the key word, no, for an emergency physician. So I just want you to look at this picture. And what you find is that you can see, you can describe that a gentleman is being brought in the wheelchair to the hospital. Here there is a lady who is on oxygen. She is sitting in wheelchair as if she is in a cardiac care unit where she is receiving oxygen with dopamine infusion. And it is her day 19. Here there is a woman and her daughter, and they are walking past the corridor. This is what we can see. And this is what we can think. Now, I want you to now see this video. Now, whatever photograph we saw shows that he has been dreading this appointment for a long time. When rather than looking at the face, you look at the feelings. All this part I could have shown you only photograph. Now we are seeing it in real. Husband is terminally ill, visiting dad for the last time. So whatever we see, so would we treat them differently if we just look at the patient or a picture? More than that, we look at the video, or we get the context. If you look at the picture, maybe our eyes are looking at it. If you look at the video, our feelings, it's three-dimensional. When you try to understand what they are feeling, the person is inside, but the family is outside. Small child is there, mother is there, father is there. That is very important. I often tell in Port Krishna, those who are from here, they know. Suppose you have got an ulcer here and somebody is doing dressing every day. Today one houseman, second day second houseman, third day third houseman. On fourth day, one houseman comes and he does the dressing in such a way that you get maximum pain. When he's rough. Suppose his dressing lasts for 1 month, what you remember is the worst pain. Lord may not dressing chalu, but pehla aata hai. So the greatest pain requires greatest healing. The greatest pain happens in ER. It happens in ICU. It happens in OT maybe. Greatest pain in life. And greatest pain in life requires greatest healing power. It requires somebody to put hand on the head of the patient's relative. Just like this. I didn't listen to your non-verbal convey of empathy. That is what is required. And that is what makes a difference. Having done all the things, whether it is ACA 2025 guideline or 22 guideline or 27 guideline or whatever, few things here and there. What matters is the human touch. And that, if an emergency physician can develop, I think it becomes a temple. One who is going to die will die anyway. We can't do anything. That person will, even if his family member has died, he will have, you did everything for us. That's all I think I will share right now. Thank you.
Thank you, sir. Sorry for keeping you waiting, but this last session really matters. It just tells us that maybe by just reading the first page of the book, you might not understand the whole concept. So there is a lot which is going on around there, and we need to understand. If once we understand them, maybe there might be some other help which they receive, the emotional touch, the care, and it matters a lot. Definitely. We'll take care.
Thank you, sir. Respected dignitaries, esteemed faculty, dear colleagues and enthusiastic participants, as we come to the closure of this enriching segment of Kemkon, it is my honor to propose the vote of thanks. First and foremost, I extend my heartfelt gratitude to all our speakers, panelists and esteemed chairpersons for sharing their invaluable knowledge and insights. Your expertise continues to inspire us, guide us and help us in delivering better emergency care. A special note to our institutional leaders, consultants, residents and to the whole organizing committee for this belief that yes, we can organize a conference 2-day long. The staunch faith that everything that we have planned will end up in execution and that too this fabulously. We are deeply grateful to our technical support team, support staff and all the volunteers, the unsung heroes working tirelessly. So as a part of the token of our appreciation, we would like to felicitate our volunteers as well. But
first let's start with something everybody is waiting for, the prize distribution for paper and poster presentation. We are extremely sorry for the delay, but let's get started. So for paper presentation, we have first and second rank. For poster presentation, we have first, second and third rank. I would like to call Dr. Sapna ma'am.
So I guess all waiting for the prizes are here.
Yes. Can we please ensure that all the paper and poster presentation people are here? Starting with poster presentation. So the first prize for poster presentation goes to Dr. Ayushi Kumari B. Rathod.
Yeah, she decided that at least one prize she will take.
The second prize goes to Dr. Akar Jasani and Dr. Devani Agnesh Kumar. Third prize goes to Shah Kavita Rajendra Kumar and Prajapati Mehul Kumar. Thank you, ma'am. For prizes of paper presentation, I would like to request Dr. Harsha Makwana, ma'am. Any guesses for paper presentation? Okay. Sorry, sir. Just for the camera footage we are waiting. Yes, that is, documentation is very important. Okay, so the first prize goes to Dr. Shyam Dholakia. Second prize goes to Dr. Avichal Dani. Thank you, ma'am. Now our team black. Can I request Dr. Hemlata Kamath, ma'am? So let's start. Is everyone present? No? Okay. Harshvardhan Chauhan. Ujjwal Parmar.
Hello. Pushti Kotak. Sawmill. Aman Agrawal.
May I request Dr. Alpa, ma'am?
Hemiksha. Kashvi. Can someone else? Akriti. Ved. Vanshika. Vishal. Okay, Helena, please come on stage. I can give it to you.
May I request Dr. Harsh sir to felicitate Helena?
Thank you so much, dear volunteers, for being so active. Many of them are just done with organizing Horizon not less than 1 week ago. If somebody tells me that આવતા અઠવાડિયે બીજા ઇવેન્ટમાં રહેવાનું છે, I would definitely say no. They did Horizon for 1 week, very successfully, very well planned, and still they showed up for Kemkon 2026. Thank you so much. A lot of them, I mean 2 of them are even second year MBBS students. Thank you so much for being a part of our conference. It would not have been possible without you guys. And also Dr. Helena
आई गया चल रेडी